Hello, thanks for tuning into this virtual SAEM conference presentation. I'm Brett Biebelberg, a researcher in the Department of Emergency Medicine at Massachusetts General Hospital, and I'll be presenting our abstract, The Bacterial Infection Symptom Complex Criteria, Predicting Sepsis from the History of Present Illness. And this is our team of researchers who collaborated on this work. So as background for our research, in prior reports, we've classified patients with sepsis as having either explicit or vague presenting symptoms. And we found that treatment was more rapid and outcomes were superior for septic patients with explicit symptoms. However, we lacked an optimal decision tool for defining explicit symptoms of bacterial infection. So we developed the bacterial infection symptom complex criteria, which I'll refer to as Bisque, and prospectively evaluated their diagnostic test characteristics. This is part of our broader work to develop decision tools and care paradigms to accelerate sepsis treatment and answer questions such as, under what conditions should you administer rapid testing and/or empiric antibiotics even before diagnostic results are available? So first, what is Bisque? Well, it's a set of infection criteria determined entirely from the history of present illness. And why is using the history of present illness important? Well, again, our focus is how do you take better care of sepsis patients early on before you may have all your diagnostic results. Our prior work showed that for septic patients who came in with vague symptoms or normal vital signs, there were delays even in diagnostic testing. But the history of present illness is available upstream of any testing. So for the Bisque to be satisfied, it requires at least the following. That is, at least one localizing symptom, at least one inflammatory or constitutional symptom, and no probable alternative etiology. Now, here as an example is the Bisque for bacterial pneumonia. So a patient satisfying the pneumonia Bisque may localize to the chest, experience fever, and lack signs of likely alternative etiology. So in other words, there's nothing like a runny nose to suggest that this is just a simple virus. And using the same paradigm, we also developed Bisque for urinary tract, intra-abdominal, and musculoskeletal bacterial infections. So our methodology, we conducted a retrospective review in the emergency department of our tertiary care hospital, and we studied two cohorts of adult ED patients over a period of 24 months. We first studied a random cohort of 730 randomly selected patients with at least mild vital sign abnormalities, so at least a systolic BP less than 100 or a heart rate greater than systolic blood pressure. Now, the reason it's important that we looked at mild vital sign abnormalities is because our prior work showed that half of our septic patients presented with no hypotension or just mild abnormalities before later developing life-threatening signs. Now, among this random cohort of patients, only 19% had sepsis. So to better define the Bisque sensitivity, we also added a set of additional septic patients, shown here as the SEP1 cohort, and visually displayed here to the right. And we studied just over 1,500 patients in total. Now, for both cohorts, we isolated the text of the history of present illness, and our reviewers were blinded to all other patient data, including cohort membership. So the reviewers did not know whether the patients they reviewed had sepsis or not. So our results, our random cohort had 138 septic and 592 non-septic subjects, so a sepsis prevalence of just under 20%. And the Bisque sensitivity for sepsis was 36%. So to be fair, it's not sensitive, but the sensitivity is repeatable, which I'll show in a moment, and the Bisque has high positive predictive value, over 50%. So if you have a patient who has at least mild vital sign abnormalities, again, not necessarily even shock vital signs, just mild hypotension or tachycardia, and they are Bisque positive, then they are probably going to end up critically ill with sepsis. So at the least, you need a rapid workup, if not also empiric antibiotics, before you have confirmatory testing. And our SEP1 cohort of septic patients had 793 patients, and as mentioned, matched the Bisque sensitivity in the random cohort. So now to summarize our findings, Bisque was an objective tool to identify a subset of patients who likely had sepsis solely based on their history of present illness. And Bisque may therefore be a useful component of a sepsis evaluation protocol. The Bisque screening can be done earlier and does not require diagnostic data like lab results. Specifically, if a patient is Bisque positive and has even mild vital sign abnormalities, today's results suggest that this is someone who needs very rapid testing and possibly empiric antibiotics. So we plan to move this into a broader sepsis protocol, but we acknowledge that a major limitation of Bisque is that it only applies to about a third of sepsis patients. So a comprehensive sepsis protocol will need to account for the other 2/3 of patients as well. This work was supported by the Nihon Kohden Corporation, and Nihon Kohden has licensed a patent for an electronic sepsis management system from the Authors Institution. We have no other conflicts of interest to disclose. Thank you very much.